to us, seeking that they would be one of the groups that would come before us. We're holding 3 sessions on childcare, and I would propose that they would be one of those groups that would come before us. And it was an oversight, I think, on our part not to have included them, but I think if we can accommodate them, we should. Thank you.
Look, I spoke briefly with Mr. Gilvenew, and I agree in principle that we should certainly look, given that there's both governments here and in Belfast or in Stormont are adopting a cross-border approach. But look, we can discuss the detail of that and who's going to come in for the childcare sessions on Friday morning. Deputy Carthy.
Chairman, we received correspondence from Jim Breslin in relation to this committee's response or request regarding having a view with regard to the oversight of secondary legislation. I have to say I'm really disappointed and a little bit alarmed by the response of Mr. Breslin, in which he says he's consulted with the Minister for Health, which essentially tells this committee that he isn't going to engage with us in terms of pre-scrutiny. He points to the fact that under Oireachtas oversight that either house of the Oireachtas can annul a piece of secondary legislation. Well, one of the houses of the Oireachtas can't sit at the minute, so that obviously reduces the scope for scrutiny. But we're in unprecedented times. There is no health committee in the Dáil to examine these pieces of legislation at the moment, and I think we should write back to both the Minister and Mr. Breslin asking for a review of that position. It's not about catching anybody else. This is about ensuring that all these pieces of legislation are the right pieces of legislation at the right time with the right focus in mind, and I think it would benefit the Minister and the Department if this committee had an oversight of the legislation before it's enacted.
Yeah, I note that position. Can we maybe discuss it on Friday morning at this working group and maybe reply accordingly? Okay, if that's everything, then we can move on to the work programme. There was a meeting of the working group last Friday, and members have been circulated with the draft programme to the 23rd of June. And we have secured a meeting with representatives of the WHO for this Thursday, and I'm advised that technologically it's possible, which is good news. The ECDC have agreed to answer questions. Members have had an opportunity to provide any questions they wish to ask to the Secretariat, and they'll be conveyed for reply by the ECDC. So the following meetings have been agreed in principle. Next week we'll deal with the issues relating to the impact of Covid-19 and the fiscal position and social protection expenditure, and on the week of the 23rd of June we'll examine the testing and tracing capabilities and issues relating to childcare. Is that agreed? Thanks very much. I have, regarding the chairing of meetings, Deputy Mary Butler will chair session 2 today, and Deputy David Cullinan will chair session 3, and I'll chair the session on Thursday morning. So if that's everything, I'd like to invite our witnesses to join us. What was the last? Where did we'll try to rotate it. Yeah, okay, we'll go to Fianna Fáil first for, I think, 10 minutes, then Sinn Féin for 10 minutes. That's yourself, Deputy Carthy. Yeah. And then Fine Gael, I think it's for 5 minutes. This is the first Fine Gael speaker. 10, and that's Deputy Burke, is it? Yeah, okay. And then the normal progression from there, Greens, Labour Party, Social Democrats. Is that? Okay, thanks very much. I'd like to thank Dr. Cillian de Gascun, Director of the National Virus Reference Laboratory, for joining us, and Professor Philip Nolan from NUI Maynooth, the President of NUI Maynooth, for also joining us. I wish to advise the witnesses that by virtue of Section 17(2)(L) of the Defamation Act, witnesses are protected by absolute privilege in respect of their evidence to this committee. If you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to a qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise nor make charges against any person or entity by name or in such a manner as to make him, her or it identifiable. Members are reminded of the provisions within Standing Order 186 that the committee shall also refrain from inquiring into the merits of a policy or policies of the government or a minister of the government or the merits of the objectives of such policies. And just to reiterate that we expect witnesses to answer questions asked by the committee clearly and with candour, but witnesses can and should expect to be treated fairly and with respect and consideration at all times. If you have an issue with regard to that, or you feel that you're not being treated fairly, I'd ask that you bring that to the committee's attention immediately. Dr. de Gascun, can we have your opening statement, please? And could I ask that you, it has been circulated in advance, could I ask that you limit it to 5 minutes, please? Sure. Thank you.
Thank you. Good morning. I would like to thank the Chairman and the members of the committee for the invitation to appear before you here today. I want to wish you well in the important work you're undertaking on behalf of the Oireachtas. The invitation that I received indicated that you wish to focus in particular on two issues this morning. Firstly, on the specific issue of minimising the risk of Covid-19 in the context of the phased lifting of restrictions, and secondly, with regard to the current understanding of the behaviour of the virus and the prospects of a second wave of the pandemic occurring. I am, of course, happy to assist the committee with answering any other queries that you may have insofar as I can. I would like to take this opportunity to acknowledge the immense grief that many people have experienced over recent months due to Covid-19, and I would like to express my deepest condolences to all of those who have lost friends and family during this pandemic. I would first like to explain my own background, as that may be helpful in gaining an understanding of my role in relation to the response that has been mounted to Covid-19 in Ireland. I am a medical virologist by training and have been Director of the National Virus Reference Laboratory at UCD since December 2013. UCD NVRL provides a clinical diagnostic and reference virology service for clinicians, both hospital and community-based throughout Ireland, and indeed has been doing so since 1963, when it was established at the behest of the Department of Health to carry out surveillance for poliovirus following the introduction of the polio vaccine into Ireland. In that regard, the NVRL remains the World Health Organization accredited national polio laboratory for the country. It is also the WHO National Laboratory for Measles and Rubella and the WHO National Influenza Centre for Ireland, contributing data annually to the Global Influenza Surveillance and Response System. In fact, Ireland was one of the founding members of the Global Influenza Surveillance Network, as it was then called when it was established in 1952. The NVRL is accredited by the Irish National Accreditation Board to ISO standard 15189, and in a normal year the NVRL performs over 950,000 tests on more than 350,000 samples. When SARS-CoV-2, the virus that causes Covid-19, first emerged, the NVRL was the laboratory designated to undertake testing nationally, and as the epidemic progressed, the number of laboratories with the ability to perform testing increased, and there are now over 40 sites at which testing is performed. With specific reference to Covid-19, I act both as a member of the National Public Health Emergency Team, and I chair the Expert Advisory Group, which provides technical recommendations on specific issues to the NPHET as well as to the HSE. In the context of the current pandemic, I would note that SARS-CoV-2 is a novel virus, and there remains much that we simply do not know. In the first instance, we do not know the precise origin of the virus itself. SARS-CoV-2 is the 7th coronavirus known to affect humans and is a member of the Sarbecovirus subgenus of the Coronaviridae family. While bats are regarded as the most likely natural host for the virus, the recombinogenic nature of coronaviruses means it can be difficult to identify the ultimate source, as different parts of the genome can have different origins. This is in contrast to influenza viruses, for example, which do reassort but do not typically undergo homologous recombinations within RNA segments. As such, ascertaining the source of a novel influenza virus, such as the pandemic virus of 2009, can be reduced to a question of where each of its segments originated. We believe the likely source of SARS-CoV-2 to be bats because following surveillance carried out after the SARS pandemic of 2003, we know that there are hundreds of coronaviruses circulating in bats. In addition, the most closely related virus to SARS-CoV-2 to date is a coronavirus that was identified in a Rhinolophus affinis bat sampled in the Yunnan province of China in 2013. The interesting thing about the 2013 virus is that despite being almost 96% identical to SARS-CoV-2 across the genome, the part of the genome that encodes for the protein that would allow the virus to infect humans efficiently and enter into human cells is actually quite different. It is this receptor binding domain part of SARS-CoV-2 that is in fact more similar to coronaviruses that have been identified in Malayan pangolins, which initially led to speculation that a pangolin could have been an intermediate host for SARS-CoV-2. However, analysis of the available sequence data suggests that the most likely divergent state of SARS-CoV-2 from its most closely related bat coronavirus ranges from 1948 to 1982. This would indicate that the SARS-CoV-2 lineages is not a recent recombinant, and that despite intensified characterization of Sarbecoviruses since SARS, Viruses closely related to SARS-CoV-2 have been circulating unnoticed in horseshoe bats for many decades. The occurrence of a third significant coronavirus emergence in 17 years, together with the high prevalence of these viruses in bats alluded to earlier, means that these viruses are likely to cross species boundaries again. As the committee carries out its important work on Covid-19, I would ask it to do so, therefore, with one eye on the future, to ensure that Ireland can learn lessons from this experience and be better prepared across all sections of society and the health service when the next pandemic occurs. Thank you. I'm happy to answer any questions.
Thank you, Dr. de Gascun. Professor Nolan, can we have your opening statement, please? And again, I'd ask you to limit it to 5 minutes.
Thank you very much, Chair. And conscious that we, as individuals and as a society, have faced difficulty, tragedy and loss over the last just 100 days, and knowing that significant challenges, as Dr. Gascun has alluded to, significant challenges remain ahead for all of us, it's very useful to take an opportunity to examine our collective response to Covid-19 and to learn what lessons are to be learned. And it's in that spirit that I really welcome the opportunity to be with you here today, welcome the work that you're doing, and thank you for the invitation. The emergency response to a pandemic can be supported and informed by the expert advice of epidemiologists, statisticians and disease modellers, whose analyses and insights can help us understand the spread of the disease, model and forecast possible future scenarios, and monitor the effects of different interventions. The process of mobilising a specific Irish epidemiological modelling advisory group began on the 8th of March. It was formally established on the 11th of March 2020 and first met on the 12th of March 2020. The group is made up of almost 50 researchers, academics and practitioners with a very wide range of expertise, forming an interdisciplinary team with the required competencies to analyse, monitor and model the spread of Covid-19. The terms of reference of the group include gathering evidence on the epidemiology of Covid-19, essentially how the virus is transmitted and how people become ill, using statistical approaches to monitor and understand the outbreak in the Republic of Ireland, developing epidemiological models to forecast probable scenarios for numbers of new cases of Covid-19 over time and to monitor the impact of public health interventions, developing a healthcare capacity, demand and resource model to assist the health sector plan for the possible impact of each of these scenarios, and developing analyses on the geospatial characteristics of the outbreak in Ireland. We present our analyses through the Chair to the National Public Health Emergency Team at least weekly, and key conclusions are also shared weekly with the public through the Department of Health briefings. We need to be aware at all times that statistical analyses and mathematical models provide very useful insights, but also have important limitations. So our input has always been contextualised within the wider public health expertise available within IMAG itself and NEFIT. The work of the Irish Epidemiological Modelling Advisory Group has offered special insight into the management of the outbreak in Ireland. We provided early evidence from international studies on the particular characteristics of how SARS-CoV-2 is spread, complementing and reinforcing the work of the expert advisory group chaired by Dr. Gascun and the Health Information and Quality Authority. Our early modelling work demonstrated that mitigation, the strategy of mitigation or flattening the curve alone, would not be an appropriate or sufficient response. Rather, in the early stages of this epidemic, it became clear that we must suppress transmission of the virus to very low levels in order to properly protect public health. Colleagues have also been able to provide NEFIT and government with important insights into the effectiveness of different public health interventions in reducing the numbers of cases, the force of infection and the reproduction number. Our focus is now shifting to monitoring, early warning of and rapid response to any significant resurgence of the disease into the future. This pandemic has allowed me to see up close and independently the different elements of a response to a public health crisis. And I want to conclude, speaking as a citizen and witness to this, by recording my admiration, first, for the people of this country, for their fortitude in the face of this crisis and the diligence and care with which they have attended to public health advice. Second, for healthcare workers, including and in particular those working in public health, amongst whose number I count colleagues, friends and family members, for their courage, dedication and professionalism. Third, for the very many public servants that I have encountered across the Department of Health, the HSE and other agencies who have impressed me deeply with their ability, collegiality, humanity, work ethic and effectiveness. And finally, for the 50 or so members of the Irish Epidemiological Modelling Advisory Group, who in addition to their normal duties have, through their expertise and sheer hard work, made a modest but important contribution to our response to Covid-19. I'm more than happy to answer any questions that the committee might have about the nature of our work.
Thank you, Professor Nolan. Okay, I'd now like to call upon the first Fianna Fáil speaker, Stephen Donnelly. Thanks, Chair. For 10 minutes.
Dr. de Gascun, Professor Nolan, you're very welcome today, and thank you for attending, and thank you for your ongoing work. I know you've both been very busy in different ways supporting the work of the Public Health Emergency Team, the Department and the various healthcare officials working on our response. I'd like to get your response to the open letter which was published yesterday. I'm sure you've both read it. It was an open letter published to government signed by over 1,000 scientists in Ireland. And it says, our current policy is to live with the virus under a long-term mitigation strategy and the risk of future surges and lockdowns until when or if a vaccine becomes available. We've all heard scientists over the last number of weeks, including microbiologists, immunologists and virologists, saying that under the current approach, a second wave of this virus is highly likely, and some say it's inevitable. If a second wave comes, we're looking at closing the schools down again, possibly in the same month that they're opening. We're looking at businesses being closed down. We're looking at very serious restrictions on people's civil liberties. We'd be looking at the almost complete shutdown of the healthcare system for a second time. Can I ask you, given the starkness of their warning, given that over 1,000 scientists have signed it, and given that if they're right, we need to do things differently, in your expert opinions, are they right? Is the strategy to live with the virus, albeit at a suppressed level, accepting that there is a decent chance that there will be a second wave, and we've all lived through what happens when a wave of this virus arrives? Are they right in what they're saying?
That I'm sure Cillian will have views also. I mean, this is not simply a question of being right or wrong. As Dr. Gascun has pointed out, this is a novel virus. There's a lot we don't know about the virus. There's a lot we don't know about the effectiveness of different public health interventions. So in any such context, you're going to have different scientists who will have different judgments based on the evidence available to them, the incomplete evidence available to them. So that's the first thing I say. It's not unusual for scientific knowledge to be contested. The people involved in that, I know many of them. I don't need the caveats.
I'm just asking you, in your opinion, as the professor who is leading the entire modelling work for the state, in your opinion, are they right?
And we're supporting NEFIT in it, and you will have heard the views of the Chief Medical Officer on those assertions. So my view is that taking all of the evidence available to NEFIT, first of all, I need to be clear, the strategy is not one of mitigation. I've made that clear in my opening statement, and NEFIT has made it clear in public. It is not a question of living with an ongoing significant level of transmission of the virus. The strategy is one of suppression. Suppressing the virus to very low levels.
Sorry, again, just in the interest of time, I just want your opinion as to whether or not they're right.
So my opinion is that the strategy, as laid out, as recommended by NEFIT to government and as adopted by government, is the right strategy for this country at this time. And just one important...
Sorry, just to be clear, I'm not asking you about... You're answering a different question. Chair, it's okay. It's okay.
It's not really. I mean, I think he has to be allowed to answer his question, and then you can come back in.
Yeah, what I'm telling you is that in the face of incomplete information, different scientists will have different views. NEFIT and government are charged with putting in place a response that's timely, proportionate.
No, sorry, look, we know all that. So in your opinion, am I safe in saying that you disagree with them?
I'm giving my view. My view is that the recommendations of NEFIT for how Ireland should manage this pandemic are the correct recommendations. I support them. They accorded my own judgment and the judgment of my team. And the point that I want to make is no strategy utterly insulates us from the risk of the virus re-emerging in our society.
We all understand that. Thank you. Can I ask you, how likely is a second wave, in your opinion?
So it's probable that at some point in the future, the incidence of this disease will increase again in our society. How big that increase will be, when it will happen, how difficult it will be to manage is very hard to predict. But there is something that I can tell you, just one output, for instance, of a modelling study. If we had changed our regime on the 18th of May and the reproduction number on the 18th of May had gone up to 1.6, we'd be looking at about 500 new cases by the 19th.
No, I know, but sorry, just in the interest of time, I'm not trying to be rude. The question I'm asking, I know there is a lot of uncertainty, yes, and I know scientists have different views, but you're the guy leading the modelling work. I'm asking, in your opinion,
and I was about to give
how likely is a second wave, and when might we expect it?
I want to be very careful with the term second wave. Second wave gives the public the impression that some overwhelming reoccurrence of the disease will wash over them into the future. What we do know is that across Europe there will be renewed outbreaks of the disease of varying size. You could describe them as small second waves, or you could describe them as manageable outbreaks. So my view is that we will, across Europe, perhaps somewhat randomly, see new outbreaks of disease which we'll be required to monitor and make sure that they don't become very significant second waves. And public health colleagues will be required to intervene and control so that the disease doesn't spread beyond that manageable outbreak.
Thank you. Can I ask, how likely do you think we are to see a second wave of sufficient scale that we would have to look at closing schools down again, closing businesses down again, restricting civil liberties again? That really is the question a lot of people want an answer to. And I know there's no perfect answer. I'm just looking for your opinion.
So I'd say two things in response to that. First of all, the management of any second wave will be different from the management of the first wave. The wave is likely to be different, and we know an awful lot more about how to manage this virus than we did the last time. So one might imagine that there could be more targeted measures introduced to control future outbreaks before the sort of blanket measures that we've seen in this context. I'm not evading it. I simply can't give you a probability for a second wave. How likely is it, or how unlikely is it?
Do you? I know I'm not looking for a number. I appreciate that would be an impossible question for you to answer. Do you think it is extremely unlikely? Do you think it is highly likely, or have you absolutely no sense for how likely it is?
Honestly, I think it's possible. It would be arrogant of me. We can't predict the future, and people who do my kind of work and Cillian's type of work, we need to be humble. There's lots we don't know. So right now, on a precautionary basis, we need to plan as if it's possible, and make sure that we have all of the contingency plans in place to deal with a tough scenario should it eventuate in the future.
Thank you. Can I ask, one of the other questions that one of the other statements in the letter, it says, right now, public transport is planning for 20% of normal capacity, pubs and restaurants 30%, schools 50%. I can tell you that the healthcare system is planning and operating at a reduction of 20 to 50% across the system. Is it your understanding that they will be ongoing reductions in operational capacity due to an ongoing level of the virus in our society? Or would you see the virus in the coming months being reduced to a point where essentially society, public services and businesses could fully open up to full capacity as before?
So I'll say one thing, and perhaps Dr. Gascun might want to expand on it. First of all, yes, the strategy for this country, which in time I think will become a European Union-wide strategy, is to suppress transmission of the virus and maintain the levels of disease at very, very low levels, because any significant level of disease represents a risk to people, their health, and represents the risk of a second kind of catastrophic outbreak. We will learn a lot then about what risks are possible and what behaviours carry low risk in the context of that very low community transmission. And back to the fact that we don't know everything about this virus yet. and some things that we're assuming are high risk may not actually be as high a risk as we currently think they are.
Would you foresee society getting back to full capacity by the end of this year?
I think this virus will, I think our behaviours will continue to be modified by this virus for some time to come.
Sure, but would you see schools, restaurants, businesses opening up to full capacity by the end of the year? Healthcare system?
I honestly don't have a crystal ball on that one. I don't know what we're going to learn about this virus over the next 6 months, and what we're going to learn that we can do and what we're going to learn that we can't do. So it is literally impossible for me to say precisely what the impact of this virus will be in 6 months' time. I'm sure you'll get lots of people offering an opinion. My view, having looked at this, is there's a lot of uncertainty that still remains about the future of us living with low levels of this virus somewhere in the European Union.
Thank you, Professor
Thank
Nolan.
you, Chair.
Thanks, Deputy Donnelly. Deputy Carthy.
Cahirlock, August fáilte ribh an duine isol. I suppose just to give us a sense of where we're at in terms of all the planning, and thank you, gentlemen, again for being here. I know you're incredibly busy men. And I'll start with Dr. de Gascun, if that's all right, just in terms of giving us all a sense of how good our information is today. So yesterday the department confirmed that we had 9 new COVID-19 cases. So that's a great number in terms of it's incredibly low compared to the numbers in the past. Is it fair to say that you would have had a guess as to where those 9 cases would emerge before it happened? In other words, is our information good enough now that we can know that if there are cases next week, this is potentially where they'll emerge?
So the number yesterday was certainly positive. I suppose we've often seen low numbers on a Monday, so there may be a slight weekend lag in the figures. So I think it's important that we don't
the
be too
numbers
carried away.
almost irrelevant. It's just what I'm asking is, do we know now where their clusters are? And in other words, can we be fairly confident that clusters aren't going to emerge somewhere where you don't know about at the moment?
So again, I think it's difficult to say that I know what we have an idea of what we don't know, in the sense what we have achieved is we've driven the infection out of the community to a large extent, and I think it was reported yesterday at the press briefing that we're seeing some household clusters now because people are staying at home in essence and they're transmitting to household contacts. So in essence, we've also seen a number of, I suppose, employment and work settings that have characteristics that facilitate transmission of the virus. So people working together in shifts, maybe travelling together, living together.
Meat factories.
So that's one of the examples, obviously. But I think as we reopen,
is there any other particular sector where, because so obviously we've seen the evidence that was released over the past number of weeks in relation to meat factories. Is there any other sector or particular type of workplace that is raising concerns with you?
So not that I'm aware of at this point in time, no.
Okay. So we always know as well, or at least I gather, that whatever number of reported cases, confirmed cases, there is an X number of other likely cases. So I think at one stage there was a suggestion that it could be as high as 4 times as many in reality. Do we have a sense now in terms of what X is? In other words, how many cases of COVID have there been that we don't know about but that we can assume, or that the evidence would point to suggest?
So I might let Professor Nolan come in on that as well, but I think one of the reassuring things we've seen from a testing perspective is that as we have increased the amount of testing that we have been doing over the last 2 to 3 weeks, the positivity rate has continued to decline. So that would suggest that there isn't a huge wealth of undiagnosed or undetected infections out in the community. But as I said, Professor Nolan may have something to add to that.
Yeah, and before I allow the Professor, if he wants to add something, so there is some anomalies just in terms of outbreaks. So the counties of Cavan and Monaghan have had fairly high instances proportionately. I think Cavan is the highest, Monaghan the 3rd highest. And the reason that many people find that unusual is that internationally it appears that the greatest concentration of cases is generally in large urban centres. I think if you look in most countries, the epicentres are generally in large cities. Cavan and Monaghan are predominantly two rural counties. Do you have any understanding or reasoning as to why those particular counties have had such high instances?
So my understanding is that there's been outbreak, or public health has been heavily involved in investigating those clusters and increased activity. I haven't been directly involved with that myself as a virologist, so I can't give you an answer to that, I'm afraid.
Professor Nolan, do you have any information in that regard?
So two things. First of all, we do still estimate that for each one case we detect, we're detecting the vast majority of symptomatic cases. For each symptomatic case, there's probably somebody out there without symptoms but carrying the disease that we
One other?
Yeah.
Okay.
Some early serology work suggested that there might be several others, but the more later work and kind of careful detective epidemiological work suggests that that's the ratio. The county variation, and in fact international variations, very difficult to dissect out why one county is hit more than another county. If you take out the outbreaks and kind of clusters of cases, you still see county by county variation. We need to remember that you know, Cavan and Monaghan are very close to Dublin by European standards, if you know what I mean. So it's not anomalous for the disease to be seeded in the capital, which is also the transportation hub, and then to spread out somewhat randomly in different directions from the capital.
But there are, like Louth and Meath is stand between us.
We may never find a fully satisfactory explanation for why some counties have high incidence of this disease and other counties have low incidence of this disease.
Is it something you're examining?
It's going to take a long time to tell. We're still only 101 days into this, so I think in the future you learn the full story of a pandemic when it's over. So people will be looking back through the records constantly to see if we can get any clue as to why there are these variations.
Thanks for that. So you've spoken about the second wave, and I think you've used the term probable or possible in terms of, would you both agree, and a yes or no answer this, that the success of ensuring that second wave doesn't become overwhelming will be in large part reliant on our ability to have a testing, tracing and isolate regime in place that's sufficient?
So if I could just say one thing on the second wave and then answer your question. The problem with this new virus is that when we study pandemics, they have all been influenza viruses, and they have all come with second and third waves. This is not influenza, so SARS didn't really get to a second wave, MERS hasn't got to a second wave, so that is the challenge for us in trying to anticipate what will happen with this virus. If we look at the other human coronaviruses, they tend to be seasonal. They tend to peak in the first month or two of the calendar year. So from a virology perspective, winter is something that would concern.
But Gascun, accepting that and almost leaving that aside, you agree that testing and tracing is going to be important moving forward?
Absolutely, but only in conjunction with physical distancing, hand hygiene, respiratory etiquette. They're the control measures. Testing is not a control measure in and of itself. It's one component of a public health response.
That the current testing and tracing system that's in place is sufficient for whatever might come down the line?
So I think the current testing system was set up in the context of a pandemic, and my understanding is that the HSE is working on a more sustainable, longer-term solution for the coming winter season. So at the moment, what we have, I think, has worked incredibly well, and a huge amount of work has gone into getting it up to where it needs to be. But I believe, given the way it has been established with the number of, say, volunteer staff and staff seconded from elsewhere, that a longer-term solution is required.
I have two questions, and I'll try and be as brief as possible. Maybe, Professor Nolan, you might be the best person to answer as to whether or not we have any reliable data on excess deaths for the period since March. I see in Britain they've released those figures in the past number of days. Do we have a sense of what it is for Ireland yet?
So we do. There's been a very careful work done on mortality. I'm not doing it, so it would be better if I asked the Department of Health to pass that on to you. The one thing that I do know is that we're well able to account for the excess mortality that we're seeing in terms of the mortality that we're detecting due to COVID-19. So there isn't a discrepancy between our excess mortality data and the ongoing monitoring of the epidemic, and that's a good position to be in, if I can put it that way, because it means you're seeing things as they're happening. You're not missing something.
Finally, to both speakers, there was reference to the letter that scientists wrote to government yesterday. I think a lot of people have taken an interest on it. One of the things notable from that letter was its very stark call for an all-Ireland approach to be adopted in whatever measures are taken, and we've seen some rhetoric to that end. Are you both satisfied that the North-South cooperation and interaction and the integration of strategies has been sufficient, or do you see areas where there is room for improvement?
Certainly there's an effective liaison mechanism at our level in terms of the sharing of data. The overall national strategy is not for me to comment on.
Gascun?
It's similarly. I haven't been involved in the North-South strategy, but I know the engagement has been there.
You think it's a bit mad not to have an integrated strategy on such a small island?
Thank you. Thanks very much. I think they answered the question. They said that there's interaction between their agencies, and the rest is not. Yeah, well, look, I'm going to move on to the next Fine Gael speaker. That's Deputy Burke. Did you say 10 minutes, Deputy Burke?
10 minutes, yeah.
Thanks.
Thank you very much. Could I thank both Professor Nolan and Dr. Gascun for their presentations here this morning and for work that they have done. And I would like to join with them in thanking all of the people who've worked both on the front line and behind the scenes, and making sure that we've dealt with this in a very proactive way in trying to reduce the level of deaths that would occur from it. Just in relation to, I think yesterday New Zealand announced changes, and they were very successful in locking down at a very early stage, and they now have no cases at all. I'm just wondering, from your own point of view at this stage, at what kind of time period will we have to travel before we're into a situation where we will have no cases? Are we talking about months, or are we talking about weeks, or is it a situation that it's too early yet to speculate on that?
I think the good news that we're seeing is that the disease continues to decline, even as we slowly lift, or even as government slowly lifts some of the harder restrictions that we're under. So again, avoiding groundless predictions, the positive news that we're seeing is that the numbers of cases continue to decline as we progressively open up. And the international experience is that as yet, with some exceptions, many countries have managed to maintain very low prevalence of the disease and begin to go about their business literally and figuratively more completely.
But if we have no new surge, and hopefully we will not have any new surge over the next few weeks, are we still talking about 3 months before we're into a situation where we're totally out of the woods on this?
We're not totally out of the woods on this until there's a vaccine.
Oh, I accept that, but in the sense of the keeping it suppressed.
So I think the comment that many of us have made about living with the virus has been misinterpreted. I think the best prediction we can make at the moment is set out in the national plan, which is, and that's a document which was called a living document when it's launched and has become a living document because it has found itself amenable to some acceleration as our progress in suppressing the disease has gone well. So again, I'm not being cagey. I'm simply facing the fact that predictions under such levels of uncertainty are dangerous. All I can say to you is that we've made very positive progress, and we are looking at a progressive and careful lifting of the very strict interventions, watching very carefully for any resurgence or reintroduction of the disease, and if I can be blunt, kind of growing in confidence and knowing more as time goes by. So we're 100 days into this. In another 30 days, we know at least 30% more. We probably know twice as much about how to handle this. So it's incumbent upon me to just be very careful not to pretend to know more than I know.
Okay. Can I go back to maybe? Thank you very much. Can I go back to the, the very start when the whole committee was set up on the 8th of March and followed on from there, and the one group of people that we seem to have missed out was in relation to nursing homes and mental health facilities, and I'm just wondering, from learning from that. For instance, I know there's a letter there that we got recently, a letter dated the 2nd of April to HICWA, asking HICWA to set out, to deal with particular issues. And I'm just wondering, are there issues there now that we need to plan for into the future? And in particular, over what occurred in relation to nursing homes, where we don't appear to have taken action at an early enough stage, or nursing homes don't appear to have taken action, but also the agencies involved in nursing homes don't appear to have looked at what was happening in other countries, like what happened in Italy and in other countries in relation to care facilities and nursing homes. It seemed to have been, there was a 4-week gap where action wasn't taken, and I'm just wondering, is there something now that we need to highlight at this stage that we need to be ready for?
There's two parts to that. There's the very broad public health support of nursing homes, which is not my area of expertise. Within my area of expertise, one of the things to be learned from this, and we still don't have clarity on it, is the extent to which people can transmit the disease before they have symptoms of the disease. So it's perfectly reasonable in the outbreak of a new infectious disease to isolate people who have symptoms. In the mid to late March, it began to be, I wouldn't say become clear, but began to become a concern that people could transmit the disease before they develop symptoms. So within mine and Cillian's area of expertise, bottoming that out, really understanding how this disease is transmitted outside those classic settings of having symptoms, shedding the virus and transmitting the disease. I do want to say, though, that as a member of NEFIT, my experience was that suppression of the virus in the community as the primary means of protecting vulnerable people, and then specific steps to protect vulnerable people, was a core concern. So NEFIT was looking at this information from Italy, from the United States, from the ECDC, as it was coming in, working hard to make what we could of it in terms of actionable outcomes.
But where I'm concerned about is the letter from the Department of Health to HICWA was the 2nd of April. And I'll just quote you part of the letter. It said, "I would be grateful if, as a matter of urgency, you would commence the progression of the action and provide an update to NEPID meeting on Friday the 3rd of April. So there was a gap there of 4 weeks where HICWA were now being asked to do something. And I'm just wondering, was there a presumption that this was being done? And maybe Dr. Gascun might make a comment on that. Was there an impression that work was already being done in this area when in fact it wasn't being done?
You'd honestly have to ask HICWA and others.
Well, the department wrote to HICWA on the 2nd of April, so they must have been concerned that it wasn't being done. But I'm just wondering, from your own view of being involved in the committee, was there an impression being given that work was being done to deal with the nursing homes at a very early stage, where in fact we know of a letter from the department to HICWA on the 2nd of April, which clearly indicates that the department were concerned that work wasn't being done. So I'm just wondering, what's your own view from your own involvement in the committee? No.
So from an effort perspective, my recollection is that the vulnerable persons subgroup would have been established in early March, and they would have been working, I suppose, across government with the various organisations and agencies to implement plans for the nursing homes and other vulnerable groups. I suppose, speaking as, and Professor Nolan has alluded to it, from a virology perspective, the virus tends to cause the symptoms that it needs to transmit. That's what the virus wants to do. So if people think about chickenpox, it causes lesions which are full of virus. So in this situation, typically we associate it with symptomatic transmission. We've learned recently that in the elderly, they may be asymptomatic or they may have atypical symptoms. And again, people will remember the fever, cough, shortness of breath that came out from China. And the World Health Organization mission report to China really gave us our first insight into what this disease looked like. But what's interesting from a virology or medical perspective is that the disease that we're seeing now seems to have evolved. It seems to be slightly different to the classical presentation in China. And I think that made it more challenging to control outbreaks in certain situations, but ultimately, in order to protect the most vulnerable, we had to suppress virus transmission in the community, and I think we've been very successful at doing that.
But do you think at this stage, though, there was a gap of 4 weeks when, in fact, something more proactive should have been done, working with the nursing homes, working with HICWA and the department? And I'm just wondering your own view on that, because was there a presumption within committee that this was already being done?
I think based on our meetings at the time, the work was ongoing. I can't speak to the correspondence that you're alluding to because I haven't seen it, but the understanding at NEFIT certainly was that the focus was on the vulnerable groups from a very early stage.
But I mean, this letter indicates that in fact the department were now concerned that it wasn't there wasn't a focus on those vulnerable groups.
Thank you, Deputy Burke. Deputy Noonan from the Green Party.
And thanks to Professor Nolan and Dr. Gascun. A number of the deputies have referred to the Crush the Curve and the 1,000 academics from the science community that have put forward, I think, a compelling argument to look at going the distance in terms of eliminating the virus from the community. Given that we are an island, it is a very compelling case that has been made. If you look at the progress made in New Zealand, and I would propose, Cathal, that perhaps we might have representation in from that group to maybe tease out these issues further and see, where we could perhaps make progress. I think it's worth debating further. But I think, as just in relation to today's proceedings, I think that testing does play a fundamental role in how we do exit restrictions and how we effectively crush the virus in the island. I suppose my first question, and again directed at both Professor Nolan and Dr. de Gascun, is to ask around timelines for testing. We need to have clear and deliverable timelines on testing, going from symptoms to swabbing to testing to tracing and contact quarantine, all within 72 hours. When at capacity. I'd like to ask the witnesses to comment on the current state of testing within the country.
So I suppose this is under the auspices of the HSE, so I don't have oversight of the entire pathway, but my understanding is that the target for 3 days was 90%, and I think Paul Reid said it was 82 or 83% earlier in the week. But I think that, again, the testing is in and of itself does not control the infection. What we need people to do is if they've developed symptoms and they have had a test, then they need to self-isolate and not transmit the infection onwards. So in essence, while 3 days is important, and I think it's a very good target, the reason we want to get to that timeline is because we want to prevent the contacts of the index case from transmitting the virus onwards. So if I have the infection today, there's no saving me, if you like. My immediate contacts from yesterday and today are the group that we're trying to contain, if you like. We want to prevent my contacts from transmitting the virus onwards, and that's where the 3 to 4 days comes from. We know that the incubation period, the average incubation period for this virus is in or around 5 days. Some will be shorter, some will be longer, can be out to 2 weeks. But so it's important that we get results quickly, absolutely, but the primary issue, the way people can prevent themselves transmitting infection, is by self-isolating and not having contacts. And what we do need people to do, so for example, if I'm symptomatic, I need to present quickly. I need to contact my GP today and get tested. A lot of the testing at the moment is actually, or the sampling, if you like, is same day or next day, but the majority is same day. And that means then that I can let people know that with whom I've been in contact that I've had a swab taken, and that they should consider themselves potential close contacts and they should self-isolate for a couple of days until I get my result. But the testing in and of itself doesn't control the infection. I think we need to just try and get that message out to people that ultimately it's the physical distancing, it's the self-isolation, it's identifying symptoms early, and the reason we want people to get to contact their GP and be sampled early is purely because they're eating into those days when my contacts are. So if I sit at home for 3 days waiting for this to get better, my contacts could potentially be transmitting the virus onwards, and that's what we're trying to address with a very short turnaround time. But also we do need people, once they're symptomatic, to present for care as early as possible.
Thank you. Okay. I have just a second question, if that's okay. And it's regard to testing of healthcare workers. Testing for healthcare workers is currently only for suspected cases, but routine testing has been shown to significantly reduce community transmission. And I would like to ask the witnesses to comment on the current guidelines for testing of healthcare workers in the country.
So it's a really good question, because a huge amount of work has been done in this area, and I appreciate that. In many respects, it probably seems straightforward just to test all healthcare workers. The challenge is that negative results or virus not detected results at a single point in time don't give you a huge amount of information. We're very concerned about healthcare workers because they've accounted for about 30% plus of all of the cases that we've seen. They're on the front line. Obviously, we had challenges back in the early days from a PPE perspective, so it's really important that we look after our frontline healthcare workers. I think part of the reason that our percentage is so high, our proportion is so high, is because they were always prioritised for testing, even when we had testing challenges with global supply chain issues in the early stages. But I think what we're trying to put in place, so the actual prevalence of infection in healthcare workers now is very low. So what we want to try and do is ensure that we put in place a system, a surveillance system, if you like, that targets those healthcare workers that are at greatest risk, so we can identify pockets of infection early on and contain them, rather than doing mass testing. Because the problem with a mass testing approach, as the prevalence goes down very low, is that you may actually start to generate incorrect, falsely positive results. So we do need to be careful about how we use the testing capacity that we have.
Thank you, Dr. Gascun. Thank you, Deputy Nolan. Deputy Smith of the Labour Party.
Dr. de Gascun and Professor Nolan for all your work over the last number of weeks, and best luck in the weeks ahead. Obviously, this isn't beaten yet. Dr. de Gascun and Professor Nolan, I'd like to first get your views on face masks. I'm getting an awful lot of contacts over the last number of days in particular, and yesterday from people that are very concerned about the messaging in relation to the wearing of face masks. I think, to sum it up, I think people would feel it's rather woolly, what's coming down. So what are your thoughts on the utility of wearing face masks and the directives from government on them, and do you have any thoughts in that regard or any recommendations?
Yeah, sure. So I can start and then maybe pass over to Professor Nolan. So we looked at this at at EAG from an evidence perspective, and there's certainly very good evidence that face masks, medical grade face masks, work very well in people who are symptomatic and in the healthcare setting. And that was a recommendation that we would, or an advice that we would have given to NPHET a number of weeks back. The challenge around masks in the community is that we believe that appropriate mask use is beneficial, but it's only as an add-on, an additional measure to good hand hygiene, physical distancing, good respiratory etiquette, all of that. The challenge is that inappropriate mask use can be potentially harmful and can increase the risk of transmission. And we know that the evidence base around cloth masks or non-medical grade masks is not fantastic, to be honest. There's a nice, I suppose, plausible hypothesis that people use because it stops the particles, that it's trapping the virus as well. We don't actually have great evidence in that area. We do have it as a barrier. It certainly prevents some particulate matter from spreading, and that's where it comes back to if people are symptomatic and coughing and sneezing, then the mask will prevent onward transmission of particles that we presume contain virus. But actually, a lot of the experiments that have been done to date have really been in a situation where they're demonstrating a proof of principle rather than actually demonstrating that virus is not transmitted. Obviously, the population-based studies from countries who have instigated sort of universal mask use from an early basis, I think it has worked. It's not the only measure that they have implemented, so I think there's certainly a role for it, and that's why our advice is for people in areas where they cannot physically distance that they should be wearing masks.
Would you recommend, I mean, at one point in this country a number of years ago, we sent iodine pills out to everyone with instructions on how to use for a totally different thing. But no, seriously, I mean, you mentioned, I've taken what you said earlier, that this is a seasonal, SARS has a seasonal element to it. So if we're going into winter 2020... Sorry,
it may do. The other human coronaviruses have a seasonality to them, sorry.
So if we're going into winter 2020, 2021, we may need to be tooling up our testing and tracing again. And should we be in a position that every house and home in this country, would you recommend, that has appropriate face masks with instructions on how to use, do you think that would be a good investment of resources as we enter winter 2020, 2021?
So from a personal perspective, I think that is a very good suggestion, because we know that there is an inequity where people can't perhaps afford to purchase their own face masks, where they can't, maybe they're not in a position to make their own face masks. So certainly in the context of trying to plan for something coming down the track, obviously again, we know there are significant global shortages around PPE and masks, and obviously the priority is to preserve our medical grade masks for our healthcare workers in the healthcare setting. But absolutely, there's time now to scale up manufacturing capacity. So I think the suggestion that you've made is it has an awful lot of merit.
Yeah, personally, I must say that the whole make and do links on the government website, I don't think that's appropriate or something we should be sustaining. I mean, we really need to be very strong on this because there's big concern about this. Just in relation to testing capacity, and I know when things were really at their peak in April into May, the capacity was set at 15,000 tests per day. Are we still operating under a numbers per day target, or have we moved on from that? And if we are, what numbers are being recommended by NPHET?
Yeah, I kind of never want to hear the 15,000 a day thing for a long time, to be honest. Yeah, no, I suppose we needed capacity, obviously. The 15,000 was based on trying to look at an ILI rate, or an influenza-like illness rate from previous seasons and from previous viruses, to look what the actual demand might be. And certainly we got up to a situation where we would have needed, speaking from an NVRL perspective, we would have received 7,000, 8,000, 9,000 samples per day in probably around late March, early April, and we didn't have the capacity on Ireland to do that testing. So that's where the plan came from for 15,000. But ultimately what we wanted to do was to have the capacity to implement the public health strategy that was there at the time, so that everybody who needed a test could have a test. Again, it comes back to what we were talking about earlier about not being able to predict exactly what that number is going to be, but certainly we wanted to be able to test everybody that needed a test, and certainly there was a period there, as I said, in late March and the first half of April where we weren't able to do that. Now that we have a significant spare capacity, we're in that position, and obviously we want to stay in that position.
Thank you, Dr. De Gascun. Thank you, Deputy Smith. Deputy Shortall.
Thank you for your presentations and your ongoing work. I want to ask questions about two specific areas. The first is in relation to data and the second is in relation to the strategy. And in relation to data, I would contest that we haven't been transparent enough about the data surrounding the virus. And for that reason, I would ask you your opinion on that. For example, in relation to the model for the R number. Why hasn't that been published by now? I mean, there's a very strong case for being absolutely open and transparent about all data. And there is a huge amount of data being collected and processed and analysed and that by the HPSC. But unfortunately, it's not being made publicly available. So there's three areas, I think. The model for the R number needs to be published. We need daily numbers for testing and for tracing. And we've never got those because, you know, prevalence is a factor of the rate of testing. So can we have those numbers? And thirdly, can we have details of the location of the virus, its prevalence and the death rate? Because I know all of that data is there on a small area basis. And can we have that published? So they're the three areas. In relation to strategy then, the strategy for this country has been to test, trace and isolate. But I suppose that strategy has never been operated, really, because the testing and tracing system was always playing catch-up. And the success in flattening the curve has been down to closing down the society and the economy. So I have to ask, what now is the strategy? And isn't there a strong case, given the probability, as you say, of a second wave, isn't there a need to change the strategy, especially as we're coming into the winter months? And it isn't sufficient, I would contest, to stick with that test, trace and isolate strategy. And isn't there a strong case for changing that strategy to include the measures outlined in that document from the 1,000 scientists? Thank you.
Maybe just to comment on a few of those things. I can't accept the characterisation about lack of transparency. The basic data is published every day by the HPSC.
I'm talking about those three areas that I listed in particular.
But there was also a kind of blanket assertion about not being sufficiently transparent. At daily briefing, we are then, to come to the points that you raise, working on supporting work on a new public dashboard to make more data, which is there but complex to present in a digestible way, available to the public. There's been a general theme here which I just want to address around additional measures such as test, trace, isolate, face masks. What we do know is that the mechanism by which we suppress the transmission of this virus is avoiding unnecessary contacts, maintaining reasonable physical distance, and rigorous hygiene. All of the other things are supplements to that.
Professor Nolan, I accept the points you're making there, but we have been successful largely because the society and the economy have been closed down. So, you know, in the context of it being potentially 2 years before there's a vaccine, and also the probability of us having a second wave, and us moving into the second half of the year, you know, and threat of flu and all of that, which would hugely complicate things. I mean, surely there is a need now to change the strategy that we're using to be more targeted, to limit movement of people, especially into the country, and also to be stricter about the wearing of masks.
We're talking about two different things. We were at one point approaching 1,000 new cases a day. Yeah. These very strict measures were required to suppress the level of transmission.
I'm saying, what is the strategy going forward?
Well, the strategy going forward has been set out in the published plan.
But is it still mitigation as opposed to elimination?
And it never was mitigation. It was suppression. And I think one of the questions that needs to be asked about the letter that's alluded to is, what really is the difference between the stated strategy, which is to keep numbers at a very, very low level, and this somewhat more ambitious strategy to eliminate it? And when you talk about eliminating, in other words, going from 5, 6, 7, 10 cases a day to 0 cases a day, we have to think of the costs of that versus the benefits of it. And what does it really buy us? When you get to 0 cases a day and the rest of the world is at some modest number of cases per day, how do you then prevent resurgence of the virus? Completely hermetically sealing the country? A different strategy is to suppress the virus to very low levels and then engage with our European Union colleagues to say, how is all of Europe going to suppress the virus to very low levels? Because some countries with enormous outbreaks have succeeded in bringing the disease under control. Some countries with modest outbreaks have succeeded in bringing the disease to very low levels. So a strategy that works for New Zealand, which, yes, is an island and is an island of 4 million people, but is geospatially utterly distinct from the island of Ireland. That strategy for New Zealand was fine for New Zealand, but it may not be the optimal strategy for Ireland. And I come back to my fundamental point.
Thank you, Deputy Shortall. Deputy Boyd-Barrett.
And thank you for all your work, which undoubtedly it's been a pressured time for all of you and your colleagues. And let me say from the outset, I'm a big supporter of science. And you might comment on whether one lesson of all of this is the need to invest more in scientific research in this area, and whether you feel the level of government investment in that area is satisfactory. But having said all that, I do think the issue of transparency and the governance of our response to this is an important issue, because we've been told right from the beginning that we were being led by science. And I just want to dig into that a little bit. Since early March, I've been asking for the minutes of the expert advisory group to be published, and their recommendations and advices to NEFIT. To date, and only as of about last week, we got the first 2 months of those minutes, but none of the recommendations and advices. So we're 2 months behind on the publication of your minutes, and no recommendations and advices. And that's obviously important both in terms of the past and in terms of the present, because we want to hear, I certainly want to hear, what the scientists are saying to NEFIT, and then evaluate the decisions that are made by NEFIT and the government in relation to the scientific advice. And there is, to my mind, a lack of transparency in that. So can you explain why the minutes and the advices and the recommendations are either way behind or not being delivered at all? And then when I look at the minutes, I'm particularly worried. Of those 2 months of minutes, 3 of them are significantly redacted. I haven't got time to go into the instances in great detail, but I don't see why they're redacted. I mean, for example, the minutes of the 25th of March under the heading Mask Use by Healthcare Workers in Clinical Areas, where we have comments from some of the people at the thing saying things like, can we recommend something if the supplies aren't there? Others say, others acknowledge that this is happening in other hospitals too. But we don't know what's being referred to because the critical section is redacted. But it clearly relates to PPE, health workers, and exposure to Covid-19. Why would that be redacted? Who redacted it? Because when you consider the high level of infection rates among healthcare workers, which seem to be, you can comment on this as well maybe, significantly higher, and a lot of your deliberations in the published minutes do seem to focus on the issue of the exposure of healthcare workers, testing of healthcare workers, PPE for healthcare workers, self-isolation for healthcare workers exposed, and so on. Why would these things be redacted when they're terribly important? Or to give another example, on March the 18th, there was a report to the expert advisory group showing that 77% of cases could be accounted for by asymptomatic transmission, and there was a recommendation from one at the meeting that passengers coming from northern Italy should be quarantined for 2 weeks, and it was said at the meeting that this suggestion would be relayed to NEFIT, but it wasn't. It was never relayed to NEFIT. From what I can see, because we haven't got the recommendations and advices, but it doesn't appear in the NEFIT meetings at the next meeting. So my question is, why the secrecy around the deliberations of the scientists and experts? Why the delay? Why the redactions? If transparency should be key.
Certainly, transparency is very important to us, and there was no intention of withholding the minutes and the advices, and as you said, they were shared, albeit lately, this week. Just in the context of the redaction when the request came in for the minutes, so I suppose we always anticipated that they would be published, but it happened in the context of a request that we just felt that the group should have an opportunity to review where perhaps specific individuals or specific institutions had been alluded to. And in that situation, we removed that information. And then the advices were, so we've up to two months of minutes gone through now, and April is currently ongoing, and that should be ready in the next week or so. And the advices have been provided. But I do think it's important.
No advice is provided, Cillian. No advices published at all.
Well, I will follow up on that because they've been signed off by the EAG, and my understanding was that they were going to go up online this week, but I can follow up on that for you. But no, certainly we've no problem about our discussions being aired in public. As I said, the only things we have removed is where specific individuals might have been referenced or specific institutions in the context of a discussion around, as you said, PPE, either whether that was due to, say, the number of healthcare workers infected or, say, number of outbreaks. We felt that information that wouldn't necessarily otherwise have been in the public domain shouldn't come out through a discussion from the EAG. But as I said, other than that, everything else has been left in.
Thank you.
I'm out of time.
Yeah. Just Deputy Shortall had a very specific question about the methodology of determining the R0 rate, and that was asked of Dr. Nolan, and he said that it was being peer reviewed for publication, and we haven't heard anything since. Can you enlighten us? Because it's a question that was asked again.
You're right, and we got involved in a discussion on the rest of the matters. That has been published. I think it's the 21st of May. So the work was done, then the work was written up, but it's on the methodology for the estimation of time-dependent R and the model structure that gives us the other estimation.
Can you send that in to us if it has been published?
It's on the departmental website. Great. Yeah.
Okay. Thank you. Thanks very much.
CMO's comments?
No, we were writing it up, I think, while he was here. The date I have is the 21st of May that it went up, if that's a Thursday.
That is the full model in relation to how you calculate the R number.
Correct. Yeah.
Thanks. We can maybe we'll have time for some questions at the end. Thank you for that. Sorry, the regional group, Deputy Shanahan.
To both Dr. Gascun, Dr. Nolan, for your incredible work. I think that certainly the state recognise that you have certainly given us service. Can I just ask you to comment on a couple of things, and just if you'd leave me a bit of time to come back to Dr. Nolan on a further issue, but with respect to the wet markets in China, where I know it's not definite that this coronavirus has come from there, but I think there's a significant risk has been identified in the Far East. Do you know if government is going to make any representations or the European Union in terms of trying to regulate what's going on there or to close that down? Just in terms of, and I know it's been discussed earlier here today, but some of the confusing messages that have come across from the ECDC and WHO, specifically with respect to masks, with respect to distancing, with respect to flattening the curve versus what's come out in the open letter yesterday. Is there any opportunity to try and get a consensus amongst the senior medical and policy makers? I think there's been a lot of confusion. I, as a member of the regional group, back in March asked for masks to be made mandatory where social distance wasn't possible. And at the time it was rubbish, and now here we are later on and we're talking to people about making their own masks. So I think that one of the issues that has come up in recent days is this confusion in messaging. And I think we all have a responsibility to try and get behind a single message and strategy and try and promote it. And just with respect to testing and tracing, what is the latest on the app development there? We haven't heard about it. I haven't heard anything about it in the past weeks. Are we close to a phone app and something that might help us prevent a second surge? Just on those, if you please. Yeah.
So just, I suppose, in the context of the wet markets, actually, it's a really interesting question, because that's the problem. We still, as I alluded to in my opening statement, we still don't know where this virus came from, which highlights one very significant challenge in trying to eradicate or eliminate anything. The only things that we've been able to eliminate or eradicate are those agents for which we have a vaccine and for which we are the natural host reservoir. And that doesn't apply to SARS-CoV-2. So I'm not aware of any planned representation from government to EU, but as I said, I think you do highlight an important point, because there were cases reported retrospectively from, I think, November, with no link to the wet markets. So there's still a lot of work to be done in that respect, rather. From the point of view of the masks, I know we touched on it earlier, and it really comes down to a context of the type of mask that you're using, the setting in which you're using it for the evidence base, and that's the problem with the sort of the cloth masks or the homemade masks that you allude to, is that the strength of evidence for those isn't fantastic, but we still recommend it in a setting where physical distancing and good respiratory etiquette cannot be maintained. So it is still an advice. I think there's always a reluctance to make things mandatory as a first port of call, but I would accept the observation that the uptake probably hasn't been as large as we would have expected in the last couple of weeks.
Thanks, Dr. Justice. I could ask you about the app development there with respect to testing and tracing. So
personally, I'm not involved in the app development, I'm afraid, so I can't give you any update on that.
Professor Nolan, I don't know.
Same answer, I'm afraid, on that one. Okay. I do want to make just a quick comment, though, on face masks and testing and tracing. They are really important parts of the strategy. What worries me a little bit is a narrative that they can replace other elements of the strategy. In other words, if only we had testing and tracing in a couple of hours and everybody wore face masks, we could do all of the other things we used to do. Unfortunately, that's not the case. The evidence remains that reducing contacts, being very careful with hand washing and maintaining some distance, simply not being as intimate as we used to be in our normal ways of going about business, are essential.
Thank you, Professor. And sorry to cut across here. Could I just ask you, as a member of NEFIT, with respect to the deal that was done with respect to private hospitals, and everybody accepts that it was very important that we get capacity for a surge, but we had Mr. Breslin in here last week, and he was talking about the potential for revisiting that deal, and one of the things he described was that he was bound under a mandate going forward, which the government had described previously, where there wasn't an opportunity there for doctors who are working whole-time private to continue working in that way without signing an A contract. Now, I understand there's a revisiting of that contract. Have you any insight as to what the position is going to be with respect to full-time private doctors in the review of that, please?
No, that's not in my remit.
Well, NEFIT is, I presume, giving guidance to government and giving guidance to the Department of Health here.
Not that, maybe I missed something, but not that I was aware of. I think NEFIT advises on the public health situation.
Deputy Shannon. Deputy Collins.
Thank you to both gentlemen for being before us here today. Our country has been in lockdown for many months now, which has led obviously to businesses going to the wall. And while good political work has been done on many fronts, do you think it was a mistake to allow the Italian rugby fans into Ireland after their match was called off? And do you think it was a mistake that we did not fully advise those going to Cheltenham from Ireland of the dangers of going over there and coming back?
I think maybe Cillian should answer first about specific evidence as to whether those travel-related events actually introduce disease.
So, yeah, I would take that point. So at the moment, we don't have specific evidence that the virus would have been, I suppose, particularly associated with either of those two groups of individuals. Obviously, we're an island nation with significant transport to many of our European countries on a daily basis. So I don't think we have evidence to support the assertion that they would have been the points of introduction or the only points of introduction for the virus.
Okay, thank you. And if we are going to have a second wave of COVID, obviously nobody's full sure of that, but our worry is there. Is the country prepared, do you think, for a second wave? And do you think our nursing homes and community hospitals are prepared for a second wave of COVID-19 if it strikes?
I just want to make a comment, just in case. We need to be clear we need to be very careful with the use of this second wave. I wish we didn't use it. I prefer we thought about the possibility, and I said possible, not probable, of a significant resurgence of the disease at some point in the future. So yes, it's possible that we might have a significant resurgence of disease at some point in the future. Yes, we must prepare for that eventuality. It may not happen, and we should work to prevent it happening. And yes, we have learned a great deal in the course of the last 100 days, which would have us better prepared for any second resurgence, and the strategies would perforce be different. It'll be different in nature to the first time out, and we will have more knowledge and experience which we would apply to any second significant development.
Thank you. And are you aware that some of our labs in Ireland can do same-day COVID-19 results, and do you think the HSE should concentrate on these labs in Ireland so we can speed up same-day tests and results? Yeah.
Trying. So, yeah, I think obviously the plan over the sort of the second half of March, first half of April, was to build up capacity for large numbers of testing, and obviously we had a significant number of samples that couldn't be tested in real time that were exported for testing, and we were very grateful for that. At the moment, as you said, the demand for testing has dropped down significantly, and there is capacity on the island to do that. I'm not familiar with the technicalities of the arrangement with all of the commercial partners, but certainly we want to reduce the turnaround times insofar as we can. But ultimately, what we need people to do is get themselves tested quickly if they develop symptoms, and then self-isolate. That's the control measure that's really important. Testing is just one element of the whole suite of public health measures. So we want people to identify themselves quickly if they have symptoms, and then self-isolate and not transmit the virus onwards.
Thank you. Do you think that our doctors, nurses should be testing for COVID-19 so to speed up detections in hospitals, nursing homes and clinics?
So we touched on this earlier, and I said it's a very interesting discussion, because we know that the actual prevalence level now is very low. So it's a question of how best to target individuals in the healthcare setting, and to, I suppose, to obtain usable and helpful information. Because if we test everybody on a Monday morning and the virus is not detected in any of them, it doesn't actually tell us anything about the rest of the week. So it's really important that testing in and of itself doesn't become seen as a shield, if you like, towards infection. What we really want to do in our hospitals is to ensure that we have sufficient staffing, sufficient PPE, and sufficient infection prevention control training and support for all of our healthcare workers, because they're at the front line. But the testing in and of itself is just one component of that, and as I said, work is ongoing to identify the best way to use that to support our measures over the next coming weeks and months.
Thank you, Dr. Gascun. Thank you, Deputy Collins. The next Fianna Fáil speaker is Deputy Butler.
Dr. Gascun, I couldn't agree with you more when you said in your opening statement that we need to keep one eye on the future to ensure that Ireland can learn lessons. Recent data is very encouraging, but we must be wary of a possible resurgence of the virus. South Korea has endured SARS in 2002, influenza in 2009, MERS in 2015, and now COVID-19. They have had great success in suppressing the virus with 10 times the population of Ireland. Test, trace and isolate is the three-legged stool of South Korean public health policy, as I'm sure you're well aware. Have we reached an adequate level of testing and tracing here in Ireland? And do you believe the public are buying in? Public buy-in obviously is crucial. And as we've moved to stage 2 in the last day or two, it is now more essential than ever that we have the public buy-in continues.
Yeah, no, I would absolutely agree with that sentiment, and I think it comes back to something that Deputy Boyd Barrett said earlier on about investment in research. And I think South Korea were in a position to act the way that they did very early on, purely because they had put investment in place after their experience, as you say, with the likes of SARS and with the likes of MERS in 2012. So I think from our perspective, I think what we want to do is we obviously had to react in an emergency setting to the emergence of SARS-CoV-2, but we had to put in place, I suppose, I think the term that Paul Reid used was sort of a wartime structure of sampling, of public health, contact tracing, and we had to put that in place in part because I suppose there has been, for a variety of reasons and without apportioning criticism, there's been underinvestment in our public health structures over a number of years.
So do you believe we're currently at an adequate level of testing and tracing with the current numbers we have?
Absolutely, we've certainly got significant capacity for testing and tracing, but it is based on a system that has seconded staff from other sections of the public sector who will have to go back to work, all going well, over as we reopen Ireland over the next coming phases. They will go back to their day jobs and we will still need to have a structure in place. And as I said, my understanding is that the HSE is working on that proposal.
And obviously public buy-in is crucial. No, I have another question for Professor Nolan. If I could just continue on, South Korea also utilised contact and tracing data very effectively, but they were very forthcoming in information when it came to the location of clusters. Do you accept that better knowledge of clusters and their locations here in Ireland might have led to a better outcome? I suppose I'm referring specifically to the meat factories and to the residential care homes. We were very slow to discuss anything in relation to clusters. I think it has been raised several times at this committee.
So I don't know, Philip, if you...
Yeah. Professor Nolan?
Maybe some general comments on that. I mean, first of all, test, trace and isolate is just part of Korea's strategy. Yes. There's extreme social distancing, huge use of barriers. That's the first thing. Secondly, South Korea is a different country. It's got a different view of issues around privacy and data protection than we might do. And thirdly, just to reinforce, we absolutely do have the testing and tracing regimen that we need. It is a question of sustaining it. I just want to make the point, be very careful about people asserting that test, trace and isolate is a substitute for other things. For instance, you can test too soon. If it was unfortunate enough that I infected you today, there's no point in testing you today, there's no point in testing you tomorrow, no point in testing you the day after. It's 3 or 4 days before you will become shedding virus. And so we need to be very careful about how we use test, trace and isolate, which is very important, as a supplement to all of the other control measures that we're using. So just want to make those general points.
Thank you. Could I just ask you another question, Professor Nolan? I want to thank both of you for appearing today and for your work to date. Professor, the expert opinion analysis of the committee you chair informs NEFIT and plays a major role in the implementation of modelling on the ground. The strategy of prioritising the acute hospital setting was taken at a very early stage. At what stage was this strategy applied to nursing and residential care homes?
So, first of all, that wasn't the case. The strategy at the beginning was threefold. One, ensure that the health system wasn't overwhelmed. But at the same time, we were very focused on reducing community transmission. And from the outset, if you go back to the announcements made on the 11th of March, there was specific reference to sheltering the elderly and specific needs in long-term residential care. So I know it looks like, because everybody was worried about ICU beds and acute hospitals, that the focus was on acute hospitals. In fairness to NEFIT, the focus on NEFIT was we need to suppress this in the community, protecting our acute hospitals and protecting the vulnerable. And it is always going to come back to that. You can take specific measures to protect people in congregated settings if the virus is wild in the community. But the only way to fully protect them is to have the virus at incredibly low levels in the community. If it's at high levels in the community, despite everybody's best efforts, you will get some transmission into congregated settings. And when it gets in there, as you well know, and tragically, it's very difficult to control and very lethal. So, in fairness to NEFIT, it was a tripartite strategy.
Thank you, Professor.
From a very early stage.
Nolan, thank you, Deputy Butler. Deputy Cillian.
Thank you, and welcome to both of our witnesses. And can I thank you both for your service over the last number of months and the work that you've both done. I'll put my questions very distinctly, and if I can get distinct responses, because we only have 5 minutes. We have a plan to reopen the economy. It was 5 phases, now reduced to 4 phases. I've seen the fruits of that myself driving up from Waterford today as I came into Dublin city centre. We're waiting a bit longer than we were last week to get across the city. We can see it out and about, that people are moving around more. There's more people obviously out and about. And I want to come back, Professor Nolan, to something that you said a couple of times, and you used the phrase, the possibility of a significant resurgence as opposed to a second wave. And I accept that. That's, I think, the correct terminology. You also said in response to Deputy Carty earlier that there may be the possibility of what you described as manageable outbreaks or a manageable resurgence. So what we need to know, and what I need to know, and I'm sure the government would need to know this in relation to, sorry, I only have 5 minutes, so I see the clock is 10 minutes.
Stop at 5.
Yeah, that you, Deputy Doherty has the other 5, you mentioned, when you talked about a manageable outbreak, we need to know what the reproduction number is. So at what point does it switch from being a manageable resurgence to an unmanageable resurgence? So what is the reproduction number that would tip the balance from manageable to unmanageable?
The strategy is to keep the reproduction number as low as possible. That's number 1. 2, when case numbers are very low, it's very hard to estimate what the reproduction number is. As soon as it's above 1, we're encountering difficulty, and the further it is above 1, the bigger the problem. But what really matters, and I'm not stretching out time here, what really matters is the product of the number of cases and the reproduction number.
No, I understand that, and I also understand all the other parts and the holistic approach in terms of the individual responsibilities that come into it, the what you call the control measures, and all those factors are important. But there has to be a number. So are you saying the number is above 1? So if it went above 1, that then creates a difficulty. That's where the risk becomes more unmanageable. Is that?
We've got to remember that this is a virus. It doesn't.
No, I understand
that. It doesn't accept kind of human desire or control. We can't play with it that way. You know, and again, I'm not evading the question. I'm saying is we need to keep reproduction number as low as possible and case numbers as low as possible, commensurate with the need to begin to get.
But Mr. Nolan, your job is to provide that data, to provide that modelling. We know it's a virus, and we know it's a virus that spreads, and if it spreads more quickly, and if we have more community transmission as a consequence of more people moving about, what I'm asking is what number. There has to be a number. When you're doing the modelling and you're providing government with advice, all I'm asking is that magic number, if you want to call it that, or that key number, the reproduction rate above 1?
So if the reproduction rate is approaching 1, I'll be sounding an alarm. If it's above 1, I'll be sounding a louder alarm. And if that's accompanied by a large number of cases or outbreaks that we wouldn't have expected, I'll be sounding an even. So you have to look at the risk as an amalgam of 3 or 4 different measures.
Okay, so Mr. de Gascun, can I come to those control measures then? Because obviously then to keep that below 1 involves lots of different things. And I think you're both right in saying that testing, tracing and isolating is one part of the component. We also have to make sure that we have capacity in our hospitals as well. You know that the contract with the private hospitals will come to an end. We're being told by the Minister for Health, because of infection control, we may see less beds in the system. So again, what modelling has been done in terms of the potential capacity that might be needed in our hospital? And second of all, in relation to those control measures, there does seem to be mixed opinions and even mixed signals in relation to the wearing of masks and the 1 metre versus the 2 metre. So from your own advisory group, what advice is being given to government? And if I can maybe ask you a very direct question as well. We have a plan to reopen the economy, and that's everybody wants to see it happen as quickly as possible. Are you satisfied that we have a plan to manage the virus that will coexist with the now accelerated plan to reopen the economy?
So in the context of the reopening, I think we've learned a lot more from the time that the first roadmap, the 5 phase, was put in place. We've learned from other countries, we've seen how they have reopened, and we've seen that thankfully there hasn't been significant resurgences across the vast majority of those. So that has given us more confidence in conjunction with what we've achieved locally, that we can move through the last 2 phases. They can be combined from 3 into 2 at this point. In the context of I'm sorry, I've forgotten the middle part of your question.
The middle part was in relation to the wearing of masks.
Yes, thank you.
Specifically, what I'm asking is, are you satisfied across all of those holistic measures, whether it's wearing of masks, whether it's all the other issues, that there's a plan to deal with COVID as well as a plan to reopen the economy? Are both in sync in your view?
Yes, they are. But just in the context of, say, returning from the healthcare service perspective and private hospitals and capacity, in essence, our healthcare system has been operating at a greater capacity than it should have been. You know, recommended best practice is about 80% occupancy. Obviously, we've been over that for a number of years. So I think that's the key, what we need to get back to.
Deputy Foley.
Thank you.
Sorry, my apologies. No, my apologies. Sorry, Deputy O'Dowd. I'm sorry. Sorry, 10 minutes if okay. Deputy Carroll doesn't speak.
Okay, no, thank you. I'd like to welcome our witnesses and to reflect the views of the public that you're doing a fantastic job and people really appreciate your professionalism, your calmness, your knowledge and the way you impart your activities which are proportionate to what we need to do to beat this virus. Now, I think if I can understand it, that the reason you're here is to explain, your understanding of the behaviour of the virus and how we minimise future appearances of it. And I think my view is that the largest number of people at risk are people obviously with underlying health conditions, people who are over certain ages, and obviously people who are in nursing homes or in congregated settings. And I think the evidence is very clear that if 67% of nursing homes are non-compliant with all of the regulations, and if the percentage has dropped in the last figures that we have of compliance from 27% compliant in 2017 to 23% in 2018, our biggest problem is if this virus does reappear and if we have an influenza outbreak, which is the latter is extremely likely, how we deal with that. So my question is, understanding all the information we have and the knowledge that you have, what additional steps do we need to take to protect those vulnerable people, please?
So I suppose as I can speak from a virology perspective, I'm not necessarily up to speed with the measures in all of the individual nursing homes, but I think we know at this point in time, we know that the majority of virus transmission occurs through either direct contact or droplet spread, or in certain circumstances, perhaps more so in a hospitalised setting where aerosols are generated in the course of an aerosol generating procedure. So in the context of trying to prevent transmission, it comes down to good infection prevention and control measures, which includes obviously the use of appropriate PPE and ensuring that we have sufficient supplies for PPE for all settings in the healthcare system, whether that be nursing homes, residential care facilities or acute hospitals. I think one of the challenges that we have seen in recent months in residential care facilities is that these aren't straightforward healthcare settings, they are people's homes, and that makes it very, more challenging than an acute hospital setting from the point of view of deep cleaning, disinfection, sterilising, physical distancing, all of those things. These are social settings, and that's one of the benefits of them from the point of view of managing individuals after they go into residential care. But from a virus perspective, ultimately, it can be controlled with physical distancing, with good hand hygiene, good respiratory etiquette, and it will, as I said, it will need adequate supplies of PPE and will need increased cleaning and maybe sort of a review of some of the soft furnishings and that type of thing, so where the virus is difficult to eradicate. But I think we have to learn from the experience that we've had during this during this first iteration of the virus, so that we're in a better position and more prepared for it should we see resurgence. I think what's interesting, just as an aside to highlight, is that Australia is in its influenza season at the moment, and they've had their mildest May in an influenza season for over a decade from memory. It's significantly down on last year, and presumably because of the benefits, the indirect benefits of physical distancing, good respiratory etiquette and good hand hygiene. So all of these things that we're recommending for SARS-CoV-2 should actually benefit us for influenza as well when the time comes.
I think the point is, though, and I respect your contribution there, the fact is that the staffing levels, the skills mix and the competencies in these congregating sessions are not adequate. And that's the view of HICWA. They're not consummate with what is actually required to deal effectively with the escalation care needs during a COVID-19 outbreak. So I think that is the fact, that is the benchmark we have now. Thankfully, you know, we're alerted to that now, and I know, you know, that there's a lot more cooperation between the HSE and the private and public nursing home sector, but we need to do more. And I believe that, you know, I'm not happy that we're doing enough. And the question I would have, is because of your professional knowledge, you know, in terms of, say, the flu vaccine, that should be, I presume, should be 100% administered to all people who work in congregated settings. You know, the question of face masks for people who are in older age groups. I mean, it's recommended by the World Health Organization that certain people, I think over 60 yesterday, that they should wear medical standard face masks. That's the recommendation. Now, I appreciate that we're talking about it here today, but if you go to buy a face mask, you know, even if you go on Amazon, you know the colour is blue, but you don't know if it's medical or not. So in other words, I think the point raised by the Labour Party member was that, you know, that we should have an adequate and available supply of medical standard face masks for those who the World Health Organization recommends that they should have. I don't know if you have a view on that.
Well, the first thing I would say is that it's always take any opportunity to advocate influenza vaccination in all groups, because it's vital. It's a vital component of controlling influenza. It's the most effective measure we have. Again, in the context of healthcare workers, whatever the setting, if they're engaged in near patient care, face masks are recommended, and obviously it's important that we prioritise medical grade masks for that setting. The area of masks in the community is obviously one we've touched on, and it is more challenging, certainly from an evidence base. We recommend them for people who are for symptomatic individuals, and also for those who cannot maintain adequate physical distancing in public, such as public transport or in retail settings. And that is the advice at the moment. We really want people to take that on board.
But the point is, again, the World Health Organization is saying if you're over 60, you should wear one. What's your view on? Do you not think that's where we should be?
So I think that guidance just came out, I think, earlier this week. Yeah. So certainly, as a group, we haven't had an opportunity to review it and see on what evidence they're basing that decision. To me, it seems like a practical approach, but in essence, if people are outdoors physically distanced, it depends on the setting. They don't necessarily need to wear masks sort of universally all the time. But as I said, it certainly, as new guidance that comes out from the WHO, it would be fairly standard practice for us to keep that under review and see how it impacts our existing guidance.
The point I'm making on it is just, it may not be your responsibility, but you know, if that is the recommendation,
so is the recommendation at all times or only in areas
I think
of high
over
incidence?
60, I think, is the recommendation.
But is it in areas of high incidence or at all times?
I think it's everybody over 60, yeah. Isn't
know.
that correct? Yeah. So, I mean, that's the reality. And there's a group of people who are older. I happen to be one of those, and thankfully healthy at the moment. But, like, you know, I talk to a lot of people, and obviously people are worried about their health. And if we don't have and I'm not criticising anybody here, I want to say that exceptionally clearly. We need to make sure that if that is what WHO is saying, well, then we make sure it happens. And if we can make sure that people who need the masks can get the appropriate and proper one. And if somebody is more vulnerable by virtue of their age or their medical condition, we have to make sure they get the medical mask. And if you go,
have the WHO in Thursday, but
yeah, but the point is, if you go on Amazon, and if you, you know, as people will, you know, you don't know what the hell you're buying. So I think it's important that appropriate and proper sources would be properly identified. And the last point I want to make, and again, it's only what I read, and contradict me if I'm wrong, but Hong Kong apparently has no fatalities or deaths in nursing homes for older people at all. And, you know, are there lessons we can learn from that here, if that is the case?
So I think it's really important that we try and learn lessons from any of the other countries that have had different experiences to ourselves. It's obviously in the setting of an emergency, it's obviously difficult to take those lessons, but I think the importance of the committee's work here is to try and identify lessons that can be taken from other jurisdictions and things that we can do better when this happens again, because as I said earlier, we've had SARS, MERS and now SARS-CoV-2. I think this is probably an element of our new normal in the coming decades. So I think we will see it again. But in the context of the WHO guidance, as I said, any new guidance that comes out, I don't want to preempt any decisions, but it's certainly something that we would review either at NEFIT or the expert advisory group and then make advice. The Hong Kong question, I'm not familiar with I think there are specific details. My understanding is that they locked down very early and there was, again, a whole suite of measures. So I don't know what they implemented in their nursing homes.
Very quickly.
I'm sorry.
Just very quickly, what I've read is that they prioritise older people by placing them in acute hospital rather than into nursing homes. I think that's the difference.
Okay, well, thank you for that, Deputy.
Thank you.
Sorry, Deputy Foley.
Thank you, Cathaoirleach, and welcome to the witnesses, and to acknowledge your sterling work and leadership really as we journey through the COVID-19 pandemic. There has been much discussion here this morning and elsewhere indeed in relation to face masks and testing and tracing, but as you've rightly said, Professor Nolan, there is much more involved, whether it's social distancing, hand washing and a variety of things. And in that respect, I want to raise with you an issue that has been raised with me by a number of my Kerry constituents, and it relates to virus transmission and surfaces, and specifically how long can the virus survive on surfaces, whether they're plastic, metal, wood or indeed packaging. And you know, if you could answer that bit first. I have a second question then on the basis of your answer, either or both of you.
So in experimental situations or circumstances, plastic and steel, I think it's up to 3 days has been described. But again, that's under, I suppose, experimental conditions or laboratory conditions. So it doesn't necessarily translate directly into the real world, but that's that's the evidence we have at this point in time.
Okay, 3 days. Now, I would say, for example, this query has been raised with me with, say, teachers as we're preparing for the opening of schools, businesses, homemakers, bus operators. And so in that respect, then, frequent references made to cleaning and deep cleansing and all of that. And specifically, what do you envisage for classroom settings, for bus operators? You know, when we speak of deep cleansing, what are we talking about there?
So I suppose those specific decisions, I guess, will be up to the relevant departments to make plans or put plans in place. But I think the advice on the basis of cleaning would be, in essence, depending on your footfall and the volume of people, the risk of this virus, notwithstanding the conversation we're having, this virus isn't going to jump off a surface and infect you. Mm-hmm. You will need to touch it, contact it, and then touch your face, nose, or mouth. So, in essence, people themselves need to take an element of responsibility around good hand hygiene and avoiding touching their face and avoid touching masks if they're wearing one. But in the context of cleaning, this virus isn't necessarily particularly robust. It's, you know, the standard detergents that are used for cleaning at the moment, I imagine, will be very successful. So I think it's something that we would look at a more regular cleaning regimen. So whether that's in a school, you would imagine that could be sort of an end of day clean just before the students come in the following day. I don't necessarily think. I think it's important to qualify that this is not my area of expertise. I'm saying from a virus perspective, if you want to ensure that the virus is not on a surface the following day, then after the children, if they're in a school setting at the end of the day, then the surfaces, the common touch surfaces should be cleaned down in advance of the student presenting the following morning. On public transport, again, I would imagine it comes down to an individual responsibility at passenger level, but also then from a point of view of cleaning, I would imagine that on a daily basis for a routine clean for the common touch surfaces would certainly be beneficial. I don't know that we're necessarily ever going to be able to eliminate risk completely, which is why individuals have to take a certain amount of responsibility around good hand hygiene and ensuring that they don't touch their face and
you don't
nose and
envisage,
mask.
for example, as I know some operators are looking at vacating, we'll say, a room for a day. In other words, you know, maybe vacating a classroom for a day or whatever for a deep cleanse purpose, that there's 24 hours without any children being in a room, or you don't envisage that going forward?
So again, cleansing is not my area of expertise, but in the context of what we're trying to achieve, so if we believe that there's a risk of virus being present on a surface at the end of the school day and we want to ensure it's gone before the start of the next school day, I don't think we can just rely on the fact that it's going to sort of desiccate or become inactive overnight.
Okay.
From a virology perspective.
Okay. And very quickly, just reference has also been made to the fact that there may be another outbreak later in the year, and also living with that will also be, we'll say, the influenza season. Are you confident that we are prepared to tackle both at the one time, or to live with both at the one time, or what measures are needed?
I think we obviously see every year with our influenza season that it poses challenges for the health service. But as I alluded to earlier, in Australia, we may get indirect benefits from this. If, like the measures that we have talked about in the context of this pandemic, hand hygiene, physical distancing, good respiratory etiquette, setting aside the physical distancing, good hand hygiene and respiratory etiquette is something that we probably should kind of be doing already. It shouldn't be necessarily terribly remarkable. And as I said, in Australia, they seem, although it's early days, they seem to have seen a benefit on their influenza season. So if we can carry those behaviours with us, then we may be able to impact in the context of an influenza season. If the two viruses do strike in tandem, it's certainly going to be very challenging. But I think what we've demonstrated over the last 3 months is that as a society we can control it, and I think it was really important to be able to demonstrate that and learn that lesson.
Thank you. Thank you, Deputy Foley. Deputy Doherty.
Alche Rava ar ní na hag an coste. Ich had kist Professor Philip Nolan. You mentioned in response to a question from my colleague David Culnan that you said you would be sounding warnings to government if the reproduction rate approached or exceeded 1. Can I ask you what you believe would be the appropriate public health responses in that circumstances if it were to materialise, and do you believe that further restrictions would be required in that event?
The appropriate public health response would depend upon why the reproduction number was doing that. In other words, is it a region where there's viral transmission? Is it a set of circumstances? Maybe it's a set of workplaces that the virus has been transmitted in, or worse still, that it's in the general community. And the response then would depend upon what the setting is. Perhaps there's a particular
And if it's in the general community as opposed to a localised setting?
Yeah, if it's in the general community, then we need to begin to re-escalate those measures that keep people apart from each other and therefore not transmitting the virus. But I do imagine that if there is a resurgence of the disease, it'll be clearer to us. Is it because we have restarted this kind of activity? Just the reopening. Well, I won't mention any activity because then it'll become the one.
It's possibly a one step back as opposed to going back to the starting line again.
Just remember how bad things were at the end of March and how urgent it was to stop the virus. So everything had to be thrown at it. It will be different.
I appreciate that. No, that's clear. Can I ask in relation to maybe to yourself, Dr. de Gascun, can I ask in relation to the risk, the level of risk between 1 metre social distance and compared to 2 metres? Is it 99% for 2 metres and 70% for 1 metres? Is that your understanding, or can you explain that to us?
So I think that's what the WHO is quoted as, which I think is a nice communicable message for members of the public. I think it's important to realise that this comes down to, in essence, virus particles or say droplets, not necessarily that may or may not contain virus particles. But if people cough, sneeze, if they're laughing or even speaking or breathing, we know that there are viral particles or respiratory particles, droplets coming out of their mouth. We know that the large ones drop very quickly. It's gravity. They will drop very quickly, typically within 1 to 2 metres. However, we also know that there are smaller particles that will take a longer time to drop, and they can stay in the air for a number of hours. And that's really the concern. They can also be moved around by wind currents. So we know that 1 metre versus 2 metres versus 3 metres, the further you are away, the better. However, we obviously need to get a balance right in the context of what risk we're willing to accept, and also what we can tolerate as a society. So when we looked at this from a starting point of 1 versus 2 metres, there isn't a huge evidence base that compares 1 versus 2 metres and tells you one is, what.
So do you agree that it's the 99 versus 70%, or do you have a different level of risk for each?
No, I think we would accept that,
okay.
But it's going to be very difficult to quantify because obviously things don't stop at 1 metre and 2 metres. Everything's a gradient.
And depending on how somebody coughs or sneezes
exactly.
and so on and so forth.
Yeah.
And can I ask you, is it more riskier for me to be in 1 metre contact with somebody with COVID who could be wearing a face mask than actually 2 metres away from somebody with COVID who isn't wearing a face mask? Which is riskier?
Yeah, great question. So I'm not aware that data exists. In the context, but we know that masks aren't 100%. Sorry, there are different types of masks. So it depends which mask you're wearing. But in essence, if you've got a medical grade face mask, that's not sealed to your face. So it's just tied around your ears. So there will be air escaping typically over the bridge of your nose, around the side, and perhaps under your chin. If you're wearing one of the higher grade medical masks with the filter, then that should be completely sealed. So it depends on the mask that they're wearing. But broadly speaking, a mask is better. Being further away is better, but trying to sort of give you an absolute number on that, I certainly can't.
But would it be fair to say that if the person who had COVID was wearing a mask and I was 1 metre close to them, it would be safer for me than the person not wearing a mask and me being 2 metres away from them?
So if this is somebody who has the infection, and then the further away you are from them, the better. In essence, what they're doing by wearing a mask is that they're reducing the amount of particles that they're emitting, but it's not reduced to zero. So it's reduced risk, but I'm afraid I can't give you an exact answer on it.
Can I ask you in relation to just where a lot of people are at this point in time, because there's a belief out there that the restrictions may change in September, as you said earlier on, we get more knowledge of the virus. In your view, is it going to be the case where we have social distance in our classrooms in December and January and February next year, which means really that there's only going to be 8 children in those classrooms that used to have 24, 25, 26? And what does that mean for the education of our young people? Or do you believe that as we gain more experience or evidence of the virus, that could possibly change, that those social distance measures for that cohort could change?
You can just answer very briefly, please.
No, I think it's going to be very difficult. And obviously, the guidance that we issue, we do keep under review. And if anything comes out around the context of 1 versus 2 metres that we can look at to try and inform or provide better advice, then we will do that. But based on the decision that was made, given the evidence we had to hand at the time, we felt that 2 metres was the better option.
Thank you. I just wish to ask you a couple of questions. Is there a difference between sustained human transmission and limited human transmission? Are they definitions that are readily used?
So I don't know if Philip may want to come in here as well, but so sustained human or community transmission basically means that there's ongoing transmission of the virus in the community, and limited in essence means that it's something that's going to I suppose taper out over time, so maybe in a particular setting or maybe confined to either particular geographical area or area of employment or something like that, whereas sustained typically means itself, or clusters. Sustained would typically mean it's self-sufficient, if you like.
The Department of Health recategorised retrospectively a number of cases from from community to local at one stage. Can you tell us a little bit about that? And it was in response, I think, to WHO definitions.
All right.
I think on the 25th of May, they retrospectively recategorised a number of cases.
I don't have that information at hand.
According to information, the one journalist, Mark Coughlin, has put in the public domain. But you don't have information in any event.
Not to hand, no, sorry about that.
Yeah, the types of testing, you both pointed out the inadequacies of testing, or at least at the initial period after being infected. Is there an alternative type of testing that's more effective, like blood testing, or not?
So I think it's important to So I suppose I wouldn't use the word inadequacies, if that's all right. There are limitations purely because there'll be a latency or a latent period between the time that you become infected and the time that we can detect the virus in your nasopharynx or your throat. So there is blood testing, or there is a blood testing option available. It doesn't have a role in acute diagnostics at this point in time because although tests have been developed when they've been evaluated, they lack sensitivity. So in essence, if we're doing a blood test, what we're looking for is antibody, which is the host response to the infection rather than the infection itself. And we know that takes, even from the time that you become symptomatic, we know that takes 7 to 14 days to develop. So that would even have a longer delay. However, where antibody testing can play a role, and this is work that we'll be doing the second half of this month, is at a population level to give us an indication as to how many people or what proportion of the population may have been exposed to the virus.
Just the testing that you carry out in the National Virus Reference Laboratory, how much does it cost per test?
Oh, so it kind of depends. So our test cost has evolved over time because it depends on the platform, it depends on the number of tests that you're doing, and so it depends on your yield, it depends on the staff input and all the rest of it. So I don't know that I could give you a figure off the top of my head, but broadly speaking, I suppose molecular tests or PCR tests would be in the region of probably sort of 40 to 60 euro, that type of cost. I would think that's in the laboratory setting, but as I said, it'll depend on the platform you're using and volumes.
Just going back to what you said at the very start, you said that driven the virus, so it's basically largely driven from the community and limited to clusters now. Is that pretty much where we're at? Or you said you've driven the virus out of the community to a large extent.
Yeah, so I think that's what we have seen. I think what we need to, I suppose it's important to remember that although the numbers have been very positive and encouraging over the last few days, that the case numbers that we're reporting this week refer to cases or infections, if you like, that would have occurred probably 7 to 10 days ago. So as our colleagues in public health and HSE sort of do more investigation into the cases on a daily basis, we'll get more information about those. Obviously, we saw surges around places of employment, but my understanding from the data this week is that more of them seem to be related to household contacts, which is why we want people, as soon as they develop symptoms, to isolate themselves and to contact their GP and to get tested, so they're not infecting other people in the household.
So is it fair to say that there are areas of the state in which it's not believed that there's community transmission at the moment?
It's a really good question. I don't know that I can say for definite. We know that there are areas that have not had reported cases for a number of days, if not weeks. But is it possible to say that there's no virus circulating in those communities at all?
Well, it's not to say that there's no virus, but the belief, you don't know that there is a virus, and you don't believe that the virus is transmitted in the community in those areas.
Yeah, I think,
as opposed to in clusters.
I think, yeah, certainly based on the geographic data we have, it would suggest that there are certain regions of the country that don't have an awful lot of circulating virus in the community. But obviously, bear in mind what we've said about and thankfully through the first phase of reopening, we didn't see a huge increase in the number of cases. But obviously, as we move into the next phase, we're still, based on the incubation period, we're still sort of 7 to 10 days behind the real life picture.
Professor Nolan, was that something you wanted to comment on?
Well, it'd be very, that's the point, yes. There is a very uneven distribution of prevalence across the country right now because essentially we froze the epidemic at a point in time. We need to be very careful now as people start moving around again into the future that we don't transfer it from one part of the country to the other. And can I make...
Well, at the moment, it's limited to certain... There are areas of the country that it's limited to at the moment.
Yeah. Can I just make a point about the discussion about face masks and distance and surfaces even? All of that work is based on understanding how droplets transmit. So, you know, the virus lives here for a while. You can transmit it over a certain distance. What we don't know is how likely that is then to lead to infection. So simply because the virus is there doesn't mean it's going to infect you. So part of the reason for the uncertainty around 1 metre versus 2 metres or face masks versus no face masks is even though we have evidence about what they do to droplets, we have very limited evidence about what they do to your actual chances of catching the thing. And that's why there's a constant erring on the side of caution. It's not necessarily erring, but if you're going to make a mistake, you need to make a mistake on the side of caution, not on the side of liberty.
Deputy Boyd-Barrett assures me that it's a very short question, and then Deputy Boyd-Barrett and Deputy Shortall, but then we do need to get out of here within the 2 hours as well. So, and thanks for your illuminating answers throughout.
Is that a reference, by the way, to minimum infectious dose? I'll just throw that in. But my question is this. Do you think the lack of PPE and staff shortages in our public health system, which seem to preoccupy a lot of the debates in your minutes, contributed to the high infection rate among health workers in the hospitals?
Thank you.
So we don't have time to go through it right now, but I don't necessarily believe that we have a high infection rate amongst healthcare workers. The peak infection rate amongst healthcare workers here was about 1%, and that's despite very high testing. And, you know, I have lots of people who are very close to me who are healthcare workers, and I'm anxious that they're protected, but I'm also anxious that we work with the facts. Whereas in London and what we're looking at is the proportion of cases that are amongst healthcare workers, and that's not a good measure. So perhaps in other circumstances we could work through that. As yet, it's not clear that the exposure of healthcare workers, and they're at risk, it's not clear that there was a greater incidence of disease amongst healthcare workers in this country compared with others.
Deputy Shortall, then we're unfortunately going to...
Briefly, thanks. Are there additional measures that you believe we should be taking in order to minimise the risk of an upsurge?
None, other than I am really worried that we will forget, that we'll become forgetful about the basics of washing our hands and just keeping a little bit of distance between each other. It's not so much an additional measure, but a reinforcement of those really basic things that it's so easy to forget.
And I think it's also the thing where Irish people, I think, tend to be very good about going to work when they're sick. You know what I mean? There's that sort of complex where we feel we can't call in sick, we can't stay at home. And I think that's really important as well. If people have symptoms now, respiratory symptoms for whatever reason, and in coming flu seasons, people need to stay at home, because if you're going to work coughing and sneezing, you're transmitting something.
Sure. But you don't think there's a need for any stricter quarantining for people coming into the country? Is that the case?
Well, I think we've made I think that advice has already gone forward, is my understanding. So I think if we want to suppress infection here, we need to control the virus coming into the country as well. Absolutely.
Okay, Professor Nolan, you've signalled your agreement to that. On that basis, I think we're going to have to conclude. Thank you very much. The committee is suspended until 2 o'clock. Thank you very much.